Okay, good afternoon, everybody. Special thanks to the GIS organizing committee. My name is Dr. Mohammed Shemmery. I'm a consultant cardiologist from Kuwait. I'll be presenting a case of a distal coronary artery perforation management. As we are all aware, there are different types of coronary perforations. There is a main vessel perforation, there is a distal wire perforation, and collateral perforation. I'll be concentrating on a distal wire perforation. I'll start with the case presentation, and I will go through the different decisions we had to make from the start to the end of the management of this patient. So, elderly lady, 78 years old, multiple risk factors. She's type 2 diabetic, she's hypertensive, she has hyperlipidemia, she takes oral anticoagulation for paroxysmal atrial fibrillation. She had multiple PCIs to the RCA and the left circumflex artery over a period of many years. She was admitted to the chest diseases hospital with severe exertional angina, treated as a non-ST elevation, acute coronary syndrome, having a high sensitivity troponin of around 200. She had ECG changes in the form of ST depression in leads V4 to V6, 1 and AVL, with a baseline rhythm of atrial fibrillation. Her echocardiogram showed no obvious regional wall motion abnormality. Her LV ejection fraction was normal. So the first decision we faced with this patient was whether we should do an inpatient coronary angiogram with possible revascularization, and we decided to take her to the cath lab. So that's her coronary angiogram, looking at the right system, almost full metal jacket of the RCA with fairly patent stents. Looking at the left system, again, patent stents of the left circumflex artery, mild to moderate lesion of the LAD, and there is a small obtuse marginal artery with critical lesion. So this is the second decision we have to make, whether to stent this small artery or leave it for medical therapy. And after discussion, we decided to stent this small artery. So we went in with a guide catheter, JL 3.5 guide catheter, fairly benign guide catheter, again fairly benign guide wire with a BMW, and we went in with a direct stenting, short, small stent, 2.25 by 18 millimeter. It was fairly easy to wire and to stent. After stenting, there was some haziness at the inlet of the stent, so we decided to do OCT, which is the third decision of the case. So we were worried about the circumflex ostium having trouble from the stent on the small OM. There was nothing there apart from small area of focal under expansion, which we post-dilated. And if you look at the right, the picture on the right bottom there, this is the final result with a fairly obvious extravasation from a small branch of the OM. So this is the third decision we faced. The patient at this point had no symptoms. So I'm gonna point it out there. So you could see towards the end of the picture there is extravasation. Patient has no chest pain. She was hemodynamically stable. And the decision here is whether to immediately go and seal this perforation or whether we should just wait. So just a yes or no question by maybe, if I'm allowed, a show of hands. Who would observe this patient? If you want to raise your hand. Nobody. Who would want to immediately embolize it with fat or coil it? Good number. So what we decided actually after discussion in our cath lab, we have the luxury of discussion in our cath lab. We had almost always 3 rooms running with senior colleagues. So we kept the patient in the recovery for about 1 hour. So after 1 hour, she vomited and she had hypotension with a transthoracic echo showing about 2 centimeters of pericardial effusion with signs of tamponade. So we all know that it can happen hours after distal wire perforation. So we did pericardiocentesis. We drained about 170 ml of fresh blood with good response in terms of her hemodynamics. And we did a relook angiogram. And this is our relook angiogram. You could see the pictures there. Still ongoing extravasation. So this is the fourth decision in terms of this case. After balloon inflation, IV fluids, and pericardiocentesis, the patient now is stable. Which modality to use to seal this perforation? So there are multiple options. The commonest ones are the coils and the fat. And each one of them has advantages and disadvantages. Coils, they have better visibility on the angiogram. They are fairly controlled in terms of delivery, but they are limited in availability and they carry a much higher cost. Fat almost has no cost. So we decided to use a coil. It's very important here to point out that once you decide to use a coil, you need to know which ones are available in your cath lab, which ones are compatible with which size of microcatheters. Because some of them you can use them with 1.8 French microcatheters. Others, they need a bigger microcatheters of 2.8 French. So in our cath lab at that time, we had the Axiom. So we took a fine cross microcatheter, which is a 1.8 French microcatheter. And in the first picture on the left, you could see we're exchanging the wire with the microcatheter. And in the second picture on the right, the first deployment of the Axiom coil, which has the option, well, it has the option that you can deploy it, but you don't have to detach it unless you're completely sure that you sealed the perforation. So we weren't happy about the first position, and we went more distal because it was quite difficult to visualize the anatomy of this lesion. So we deployed it, but we didn't completely release it, and we waited for about 5 to 7 minutes. And if you look at the left picture, the right picture, it does show that almost complete sealing of the extravasation. So we released it on the picture on the right, and we took a picture. We're always taking pictures through the guide, not injecting through the microcatheter, just so that you don't propagate the perforation. And you could look in this final picture there was no further extravasation, and the patient was hemodynamically stable with no symptoms. So in terms of numbers, I had a summary. In terms of all types of perforation, they're quite rare. So if I'm deriving these numbers from the largest meta-analysis of coronary perforations that included more than 5.5 million PCIs over the last 40 years. And the incidence is about 1 in 250, so it's quite rare. But once they happen, they can lead to serious complications. Almost 1 in 5 will lead to tamponade, and they carry a mortality. Once you reach the point of tamponade, the mortality goes up to almost 8.5%. Many risk factors, a lot of them available in our case, old patient, females, with multiple comorbidities, calcified tortuous small vessels, CTO, and PCIs, and the use of atherectomy devices. Again, the commonest cause is distal wire exit, almost 40% of all perforations. A high percentage needed covered stent, almost 1/4, and 17% needed the cardiac surgery. Going back to the distal wire perforation, it's very important to watch your wire. Always change your polymer jacketed wires to a workhorse wire. In our case, we use the workhorse wire from the beginning. Don't ignore it. So one of the main lessons is that you probably need to close it as soon as possible. Learn how to block and deliver with balloons. And again, know how to deliver fat or use coils. Thank you.